Hey everyone, I'm Dr. Eric Kaler. For those of you that don't know, I'm the founder here, and we're here about shoulder pain, how to overcome that without medications, drugs, or surgery. So I've got a PowerPoint presentation, and I'm going to just start with a brief introduction of who I am. I always think it's important when you're listening to someone about medical advice that you understand their perspective. So I call my perspective out so you know my perspective to help give you a frame of reference, right? So we started Physical Achievement Center because we wanted more options than currently exist in healthcare for challenging issues. Musculoskeletal issues, we have a neuropathy reversal program, we have a weight loss program, a number of different things. From my perspective, I think there's overutilization of medications, drugs, surgeries, and injections. There's a time and place for that. Research has good support for non-surgical, non-drug, non-injection approaches for a wide variety of conditions throughout the body. I'm not about limiting patients' choice. I want people to have more choices. In order to understand all the options, what's great is you guys are showing up to learn something, right? Because it starts with education. You can't choose from options you don't know about. Does that make sense? That's a basic tenet of evidence-based practice. Evidence-based practice says, hey, you know what? If the patient has a preference for a style of treatment, you ever heard of that Venn diagram, those three circles here, right? Patient preference. If there's a practitioner that is experienced, and some of that experience includes what that patient prefers, and if there's on the other circle, research that supports it, where those three circles meet, if one engages in treatment where all three of those meets, what are the chances of a good outcome? Pretty high, right? But we need to know all of our choices. So Physical Achievement Center was started to create options for individuals. We started in 2017 to help people achieve greater mobility and strength for their active life without medications, drugs, and surgery, even when nothing else has failed. So shoulder are particularly interesting because that's probably the start of the genesis of why I started independent practice, independent of other influences. So we'll get through some of these slides here. I've got over 33 years, more than that, 35 years of clinical experience, nearly all of that in Oshkosh. Raised 3 children here in Oshkosh, and I'm pleased to be able to treat in the same community that I live in. Dr. Jessica is a practitioner here. She's a fellowship trained practitioner. She's been with us for 4 years. And we've got Brock. Brock's a physical therapist assistant. Brock has lots of experience in healthcare, and he's been serving patients for over 25 years. Likes to get after it here. Ashley's a physical therapist assistant, and she's our newest team member. And she's got great hands, great heart, loves to serve. We have another practitioner coming on board shortly, Dr. Matthew, and a number of other providers. There's a picture of the current team. We want to help people create better choices for their healthcare, so they can make an informed decision. So we love doing these presentations. We've done presentations about every month, 1 or more a month, here at the clinic, in the community, YMCA, Senior Center, a number of places. And we're biased towards non-surgical, non-drug approaches to recovery. We want to be the source for help. If you're unsure, stuck, not sure what to do. And for those of you that, or you just have to live with it, ignoring it for the dreaded, some of the older individuals here, they might hear something from their providers. What do you expect at your age, right? If you can't help somebody, just say you can't help them, right? We expect everybody at any age to be able to recover. We help a few people, so there's some Google reviews online, and that's probably enough about me, right? So what I'd like is to be sure that I cover topics that are of interest to you. So I'd like you to share, if you would, your name, first name, and what your biggest challenge is as it relates to shoulder problems, so I'm sure to include some information on that.
Okay. My name is Gary Emmer. I have shoulder problems over 30 years, and to the point my hands going numb. Either you've got to get surgery or get shot up again. I got shot up about 6 times in my life, and it worked every time. It helped. I didn't cure it.
Like shots out, you're talking about
Right.
injections in the shoulder?
Injections in the shoulder.
Okay.
Well, mine is scar tissue. Playing football as a young man, I tore my rotator cuff and never knew it. I went off across country, and my whole life I suffered for it.
Got it. Appreciate you for sharing, thank you. Yes.
My name is Linda, and I've had the shoulder pain for a couple of years. I had rotator cuff surgery. In this one, I had an accident and fell on this one. So it's been a couple of years.
Yes.
Haven't been done.
Okay.
Please.
What are you struggling with? Overhead reaching, sleeping? Thanks for sharing. Hi.
I'm along with the ride.
Beautiful husband. All right. Sir.
My name is Augie. I actually come here right now for neuropathy. My hands and my feet. And it's coming out wonderful. But now my shoulder is starting to fail. They're both implants, or whatever you want to call them. And this one failed before, but I didn't know it because I was on so many drugs for pain. And I had to get it all rehabilitated so I could at least use it. And I'm afraid that's what's happening here, so that's why I'm here again, under this class,
Might affect your fishing, right?
more or less.
Gotta get back to your fishing. Okay. Let's get serious then, for sure.
My name's David. I had a ski injury. I fell 3 months ago, and I was getting better, but about 3 weeks or so, I noticed I plateaued, and I haven't gotten any improvement. Still wakes me up at night, and every single night. And I need to figure out what my next step is going to be.
Thank you. Yes.
Hi, my name is Kathy. I currently come here for my lower back and shoulder.
And do you have a shoulder issue right now, or just?
I do.
Okay, all right. What are you struggling with your shoulder?
What's that?
What are you struggling with your shoulder?
Lifting my hand above my head and sleeping.
It's interesting. A lot of people, they, like sleeping. I almost have to ask individuals, right? They think, oh, well, it's just I'm just laying funny, or it's my pillow, or something like that. But we should be able to sleep through the night uninterrupted, right? Not be hindered by pain. And our shoulder and our upper body should be able to tolerate whatever sleep postures we want to be in. Because when it interferes with sleep, like that doesn't make anybody happy the next day at their best, right?
True.
And there's actually a sleep cycle that actually helps your body repair. And if you don't get deep sleep, your body's really struggling to repair like it should on a regular basis.
Hi, I'm Molly. I injured my shoulder about 2 years ago in a very simple, embarrassing way. But it's gotten better and then it's gotten worse, better and worse. But it has never been examined. I've never been diagnosed with anything. But I can't, putting my arm back, I can't hang, like do pull-ups or anything. Like I can't just do push-ups. Like there's a lot of limited mobility and a lot of sharp pain. I've just started weightlifting again and with very restricted movements, and I've been able to do it, but I just also know what I can and can't do without pain, and sleeping is also very uncomfortable for me as well.
It would be a separate service.
I'm Laura. I had a fall going up some stairs last fall and injured my left shoulder. I came here and we worked on that. I recovered from that, and then this spring I had another fall and injured the other shoulder. So I've been working on my own using the techniques that I learned last year, and I've pretty much got it under control, except at night, especially sleeping like in positions, and it wakes me up. It's still
Thanks.
Yeah, it looks like there is still a question.
Hi.
Hi, Donna. I came here in the past for my back, and now I'm having issues with my left shoulder. I injured it this year. I had one injection done, and that worked until I re-injured it. And I had another injection, and I don't want to go that road. I don't want any more shots.
What's your concern about the injections?
Well, this last one really didn't work. And I'm still having issues up here and then on my upper arm area. And, I'm just concerned that they're gonna say, well, you just need to go in surgery. And I don't wanna do that either.
Okay.
There's gotta be another way.
Or make this quick for, if you wanna make this quick for today, and then I can look to see.
Hi.
All right, Brian, hockey injury. So it's just one of those things where, like she said, as far as just the movement up. And there was a doctor that's on the team that took an x-ray of it and said, well, if you don't wanna golf or play hockey, you know, just leave it alone until it gets too bad and then come in after that. So it's been like 10 years. So we're gonna look at something. Sleep, just like everybody else. Another thing.
I'm Alpha, and I'm coming here now for physical therapy for my shoulders because both of my rotator cuffs have been damaged. So occasionally I have issues with them, and I'm right now trying to learn to strengthen my shoulders, so I have those problems. And it's awesome.
Good, thank you. All right, so that gives me a good reference in terms of the range of things. I believe we'll be able to be talking about things that relate to your, similar to each, what you have based on what you're commenting. And then today, if you'd like, we could certainly do a 5-minute miracle, which is a chance for us to see what a hands-on assessment on the treatment that we've done. So we'll look forward. All right, so there's a number of things that can go wrong with shoulders. We're going to talk about our conversation starting with the rotator cuff, what it is and its purpose, give you some reference, give you a pretty good idea of the sort of things that bring people to these talks. And we'll talk about kind of basic anatomy of the shoulder and common causes of shoulder troubles, so that you have an understanding and appreciation of why we do some of the assessments and questions that we do when we assess something. Fair enough? Okay. So rotator cuff is simply a series of muscles that help connect the shoulder blade to the upper arm. This is a model of a right shoulder. So if you take this out of me, let's see, the collarbone comes out to meet the shoulder blade, which is a triangular structure. So that meets about where the brow line is. Then you have the shoulder blade, so when I reach forward and up and to the side, this wings out to the side. The shoulder blade has no bony attachment to the spine. It's only through the bony attachment of the collarbone to the sternum. Then we have the upper arm bone where it meets the shoulder blade. We call that your glenohumeral joint or your ball and socket joint. Most individuals, when their shoulder bothers them, like my shoulder hurts here, right? So this is where the rubber meets the road. So if I take this bone out here, this is your upper arm bone, called your humerus, and the end of that has a ball. The inside of this is a small cup. And the purpose of the rotator cuff muscles is there's a series of muscles here, and the back is called your spine and the scapula. So the muscle above it is called supraspinatus. You gotta have fancy names for stuff, so that's called supraspinatus. The one underneath it is called your infraspinatus, above and below the spine and the scapula. And there's this little muscle over here called your teres minor. It's the smallest of the rotator cuff muscles. All three of these muscles here are on the back of the shoulder, and they're counterbalanced by the muscle on the front called your subscapularis. So the shoulder blade, we have another term for it called the scapula. The subscapularis is a hidden muscle that's underneath that shoulder blade, kind of against the rib cage wall. Make sense? So the rotator cuff muscles are a series of muscles that are designed to help keep the relationship of that ball and socket joint in proper position, because the purpose of the shoulder, one of the purposes is to take your hand and move it in a large range around you, like 360 degrees. So there's lots of mobility there, right? So that rotator cuff muscle have to act to kind of keep the ball and soccer in proper relationship, so the large muscles can do their thing. What are the large muscles? Large muscles are the big pec muscle, the deltoid muscle on the back, the lat muscle that you're using when you're developing those pull-ups, right? Chest muscle when you're pushing and pulling, right? So the rotator cuff muscle aren't the muscles that a well-developed bodybuilder would flex, like, ooh, look at my teres minor there, right? Those muscles are deeper underneath those larger muscles, and they have to do their job. And stuff can go wrong with them. So lots is written about the rotator cuff muscles, and we're going to talk about that. So that's simply what the rotator cuff muscles are, is a series of muscles to help keep the tension appropriate between the ball and socket joint. Fair enough? In the past, I think it's been overly complicated. It doesn't need to be. So this is just pictorial representation of what we talked about. So we'll talk more about things that contribute to shoulder pain other than rotator cuff muscles. And we'll get an understanding of why some of the discussion has been almost exclusively in some circles entirely on the rotator cuff. So biggest mistake shoulder pain sufferers make is they do nothing. Have a great night.
Okay, great, thank you.
This stuff doesn't tend to get better on its own. I mean, if you don't have normal healing in a 4 to 6 week, 8 week period, it's probably not going to get much better. Your body tries to adapt, but at some point, if it's not getting better, it's not getting better, right? The longer you wait, the more challenging it becomes. That's not to say that you can't get better if you've had it for a while. It's just that time isn't always on your side. And you're missing out on doing those important things that you like to do, right?
Yeah, I'll be here on Thursday, so whoever happens to be here, I'll meet up with you and
Second mistake is spinning your wheels, spending time and effort on things that aren't working. So a couple things that don't work necessarily to get to the root cause might be I'm all for getting relief, but if you're just putting pain creams on that, or just trying to do self-stretches, or Dr. Googling it and trying to find exercise routines, the measure is, are you getting better or not, right? If you're not getting better, you're spinning your wheels. Like, that's kind of the definition of insanity, right? And then masking it with over-the-counter or other things might help with symptom relief. I think we're beyond the period where most people are getting opioid medications, but muscle relaxants are still prescribed. And like it or not, over-the-counter pain medications or even prescriptive non-steroidal anti-inflammatories have very real increased risks and side effects. Can anybody mention a couple of risks of non-steroidal anti-inflammatories?
I had bleeding stomach.
Bleeding stomach, right? It's one of them.
A couple of years ago, I had so much pain, I just kept taking them, eating them.
Kept taking them, right? Persistent use of non-steroidal anti-inflammatories raise heck with your kidneys and liver. And recent evidence has shown that it even increases your risk of wear and tear on your joints. It's not opinion, that's research, which the very same thing that people take it for, like, ooh, I got arthritis pain in my wherever, I'm gonna take some over-the-counter pain medication. It's at the pharmacy, over-counter, it must be safe, not so fast, right? So, and that's not opinion, that's research. It's also increasing risks of cardiovascular disease and heart attack, which is unfortunate. However, and there's other options, right? And we're going to outline comprehensive treatment, and comprehensive and individualized treatment is different for everybody. A lot of you came with shoulder conditions. If you kind of met on the street, you might say, oh, I got the same thing. I can't sleep, I can't reach appropriately, I can't reach my hand overhead. Doesn't mean you all have the same thing, right? Comprehensive treatment, we'll talk about what that looks like in terms of reclaiming full range of motion, full flexibility, full muscle control, full tolerance, and maybe even making sure that our spine, our neck, and our upper back are all in tune, so that our nerves can function. And then relying exclusively on surgery or injections to get you back to your active life. There's a number of key things about each of those. Certainly there are times when surgery is appropriate. I'm not saying there's not. And there's times when injections may be appropriate, but injections can dramatically lower levels of pain in the short term. Might even be a good window then to follow up with aggressive rehab to kind of normalize the situations that brought you to shoulder trouble in the first place. But then the result is, right, first injection might, if people have them, maybe relief for a few weeks to a few months. Subsequent ones, fewer and fewer periods of relief. And there's a certain number of injections that someone can have over a year. Does anybody know why that is?
You may want to check for the ones that are missing the data.
Why is there a limit to the number of injections that people can have?
Just the effectiveness of it.
Well, yes and no. It'll actually wear away at the underlying tissue. And that's not opinion, that's fact. Right? All right, so ultimately three ways to handle pain. One is to ignore it. You all aren't doing that. You're showing up for this. That's great. Another is to mask it, alter it with over-the-counter pain medication. Who knows what? Massage it, ointments, lotions, anti-inflammatories, that sort of thing. And then properly handle it. Obviously, I'm an advocate of properly handling it. So we'll get into this. You want to get back to confident and strong, back to a worry-free life, right? There's a heck of a lot of ways to relieve pain. If you want to help lower levels of pain, but I want it very clearly understood that what we're after is helping people lead a more confident life so they can sleep through the night uninterrupted, so they can manage their daily activities at their home, they can manage their yard or whatever they do in their scene, and they can do things that they enjoy. Some people it's CrossFit and workout, other people it's pickleball, other people it's who knows what. Pitching hay and feed to animals. Whatever it is for you, it doesn't matter, right? We want to get people back to living their active life.
No message will pop up. Basically just authorizing it.
All right. Here are some common sources of shoulder pain and weakness.
Awesome. And then just confirm that email address.
Rotator cuff tears. This gets a lot of press. There's going to be signs and symptoms of each of these. There might be some overlap in these areas. We don't have AI that you can just input, hey, I've got this and this and this, and then it spits out your diagnosis and treatment plan. We're not there yet. I don't think we'll ever get there because the body's a little more complex, but be that as it may, there might be similar symptoms that are common to different things. This is as common symptoms that might be with rotator cuff tears. Pain and weakness in the shoulder, limited flexibility, difficulty with overhead activities, pain with lifting or reaching, and muscle imbalances. There might be possible neck or upper back irritation if you're not moving your shoulder right. Can you kind of envision that the neck probably would catch some heck too because everything's not working right? Does that make sense? When I first started practicing in the early 90s, there were two things that were very prevalent and started to be used. One was the use of MRIs, which is an absolute godsend, because you can see very fine detail in the body. If you've got a pain in your lower quadrant, excruciating pain, you present to the ER, you probably want an MRI machine to make sure your appendix didn't burst and you're kind of spilling unhealthy stuff all over your innards, right? The other thing that was prevalent was microscopic surgery. So instead of cutting people open with large incisions, they could use little probes that would go into that. Well, it's an interesting confluence of things because the MRIs, when it compared to shoulders, saw very fine detail. So MRIs could see very fine detail into the shoulders, and as a consequence, every little wear or tear or imperfection in the shoulder was picked up by orthopedists as a reason to go in and do arthroscopic surgery. Make sense? So there's a couple challenges with that. So this is showing partial tears and full thickness tears of the rotator cuff. I'm going to describe that a little bit. So this is the rotator cuff. So you can think of a partial tear in the rotator cuff as a tear that goes through part of this white material here. Full thickness tear is you can peer straight through it. You can look straight through it. Like if you split that open, you can see straight through there, right? Literally when I was in clinical training in the early 90s, they said if you had a partial tear of your rotator cuff, you probably need surgery and you're not going to get better. They also said if you have a full thickness of tear, boy, you better schedule surgery right away. That was the common belief. I'm going to pass this around so you can kind of take a look at that. This shoulder model, I also want you to pay attention to this thing. This is your biceps tendon. Sorry, I'm bouncing around a little bit here. Is that okay? I'm not sending any berserk? Okay, good. So this, just pay attention to this. You can pull this apart, take a look at that. That little bony part in there, that's your glenoid fossa. Again, we've got to have complicated names for things, right? So play with this a little bit and send that around. So what they started seeing is, hey, the radiologists are the ones that make a living who read detailed examinations of x-rays and MRIs and those type of investigations, right? So they did a study and they said, hey, look, we're going to collect a bunch of MRIs of shoulders and we're going to see how many people in the general population, people who aren't having shoulder problems, actually have full thickness or partial thickness rotator cuff tears. This is out of a whole body research, taking a look at what's called asymptomatic findings. So in other words, findings of anatomy that aren't ideal, that individuals aren't having any problems with, but they have these MRIs. So it might be somebody who had an MRI of their chest wall or something like that. Does that make sense? Just took these images and they said, hey, in the general population, and this is one of the most conservative studies, and this is out of the Journal of Bone Surgery, 1995. General population, 20% of people had full partial thickness rotator cuff tears. And nearly a fifth of individuals, 15%, had full thickness rotator cuff tears in the general population. People aren't having any pain. This just shows from age 19 to 60 plus, the percentage obviously increases, right? So the body exerts some wear and tear, right? Kind of at anatomy's probably pretty decent at age 18, right? As life goes on, life beats it down a little bit, wear and tear, right? As the decades wear on. So that's one bit of information, right? Oops, going the wrong way. So this is secrets about MRI and X-rays not often told, right? So can you make clinical decisions based solely on MRI or X-rays? Typically not. I mean, you fall and you have trauma. I have a friend who just kind of did the splits and he busted his femur, right? Got to help him recover, right? Okay, that instance, yeah, the X-ray, MRI is going to show a massive break, but very few cases are that apparent. So that's something just to keep in mind. And then this is it. Wouldn't it be awful to risk surgery and realize that your shoulder could heal without surgery for rotator cuff tears, right? And then that started out a whole thing. Do rotator cuff surgery, do full thickness rotator cuff tears require surgery. And I read an article by Dr. Kuhn in 2013. And again, that was still at a time when it was believed that individuals who have full thickness or even partial thickness rotator cuff surgery needed surgical repair. And I was astounded because this article said that you have an equal chance of recovering from a full thickness rotator cuff tear with surgical repair followed by physical therapy, or you just had the physical therapy alone, right? And Dr. Kuhn is an orthopedic surgeon. To this day, he's still going around lecturing about the benefits of non-surgical care for rotator cuff. So it's a 12-week study. Individuals could opt out at any time, so the people that didn't have surgery, if they felt like they were being shortchanged, they could just raise their hand and say, I want the surgery now. So they followed these individuals 6, 12, 36, 52 weeks after their event, and they ended up the same. 75% of each group had a good outcome. One obviously exposed themselves to a lot more costs and risks, and they still went through physical therapy, right? Because any good surgery is going to follow physical therapy, right? So I thought that was pretty cool. I was like, oh, great, now I need to learn a different way to do that. There's a specific protocol that was used, right? Specific series of exercises, working with the joints, collarbone, AC joint, neck, upper back, whatever needs work on, plus specific exercises. I thought, great, my physical therapy colleagues would be all you rah rah, let's help people with non-surgical care. The research was repeated over time, all across the world, all kinds of institutions, and yet, do you think we used widespread adoption of this approach for rotator cuff tears? We haven't, unfortunately. So, there you have it. So this is the 2003 study that I talked about, 75% recovery in either exercise or surgery plus exercise. And repeated again in other studies, similar findings across the world. All right, enough about rotator cuffs. So we'll talk a little bit about that as well. So in a little bit, shoulder impingement syndrome. What is shoulder impingement syndrome? Well, you can think of our shoulder model. Everybody get a chance to play with that a little bit? I think it's kind of fun to fidget with these. Okay, so think of this is the hood of your shoulder, ball and socket joint, and this is the underpinnings, right? So when you move your shoulder up and about, what should happen is, if you've got that hood, there should be some roll, spin, and slide that occurs so that that ball and socket retain a good relationship as you reach your arm up into the sides. Can you see that? Impingement means there's kind of banging together. Not a lot of space between there. There's bursa and all the rotator cuff muscles pass through there, so if the muscles don't know what to do, or there's stiffness there, you can get what's called an impingement, where the parts just don't work right. Does that make sense? The coordination isn't right. That's called shoulder impingement. So shoulder impingement syndrome, signs and symptoms could be pain in the front of the shoulder, pain with overhead reaching activities, muscle imbalance. You see there's some commonalities between all of these. Possible pain in the upper neck. And a hallmark feature is, yeah, I reach up a little bit, it starts to be painful, and then I get past it and it's okay. Right? Shoulder impingement generally does not show on an X-ray, CT scan, or MRI. You might see this theme a little bit. It can only be detected with appropriate physical examination and history. So in other words, what the patient is telling us, we ask questions, and then we do customized examinations to rule in or rule out these sort of things. Frozen shoulder, adhesive capsulitis. So who's heard of somebody having frozen shoulder or have had frozen shoulder in the past? Yeah? Yeah. So signs and symptoms of frozen shoulder are stiffness, very stiff, and limited range of motion. You can't pick your own back pocket, can't reach across to your other armpit, can't reach your arm up, can't reach your arm to the side. All dimensions are reduced in flexibility. So daily activities are really limited. This is a hallmark feature. Well, yeah, I'm getting better. Really having to kind of do a lot of motions in the shoulder blade to try to make up for stiffness in the ball and socket. And as you're not moving your shoulder right, that's probably going to raise heck with your neck and upper back, right? There's a range of adhesive capsulitis types in the shoulder we'll talk about in a little bit. It can be, there's a really apparent one. It's really, for some reason, really common with women, kind of around pre and post-menopause, and a little more common with individuals who maybe have diabetes, but so it's a little bit of maybe a hormonal influence as well. Glenohumeral joint instability. So things are slopping around too much, right? There's not enough muscle control. So that hockey injury, maybe that was an instability at the time, maybe the skiing injury, I don't know, right? Signs and symptoms of shoulder instability, reoccurring shoulder dislocations, subluxations. You generally know when you have those. There's not a doubt when you dislocate your shoulder, that can create instability. You don't have to have a full dislocated shoulder in order to experience instability in the shoulder. So in this instance, in the impingement, there's not enough room, there's banging, right? With this, it's just sliding around too much, too flexible, right? And not enough stability. So the internal feeling of things moving around too much, that's pretty reliable for individuals. If it just feels like a sloppy movement. Pain with overactivities or throwing, and profound muscle weakness. And there'll be shoulder blade. The shoulder blade, when you watch the shoulder blade reach up, that might be kind of funky. It may not look right. Possible neck or upper back pain. Clavicular joint stability will not show on CT scan, X-ray, or MRI, unless of course you present to the ER with it completely dislocated, right? Physical examination and history is taken. See some evolving themes here? All right. Labral tears. So if you remember seeing this in here, the little ball component of it is very small relative to
Behind your laptop.
Oh, thanks. Yeah. The little bony part is kind of small in relation to the ball here. So it'd be kind of like got a big ball sitting on top of a very small cup. So there's an item that the body uses. It's called a labrum. It just extends like a larger cup around that to keep better contact between the ball and the socket. Does that make sense? It's called your labrum. So you can have labral tears as well. Common signs and symptoms: pain in the shoulder, sensation of clicking or catching. Decreased shoulder stability, could be slopping around, so this and the previous one could be related. And shoulder blade muscle imbalances. Possible referral pain to the neck or upper back. There's a lot of stuff that can go on with the shoulders, right? This kind of reminds me of my boys were all in Boy Scouts, so I was a good Boy Scout dad. I took all kinds of Boy Scout training, took wilderness safety. Did you know that I know how to treat an impalement in an eye of a stick? After I learned that could happen out in the wilderness, I'm like, boy, maybe I don't want to go out there so much. But anyway, I digress. Biceps tendinopathy. So we talked a little bit about that biceps tendon. This is really common. If someone could take their finger and say it hurts right here, it's in front of their shoulder, that's the biceps tendon. Right? Does that sound familiar?
Oh yeah, right here. If I massage it, it's worse.
Yeah.
I don't dare touch that sore spot.
You know that makes me want to go in there and test it out, right?
Right, yeah. Just when I want to take a hammer, it's like pounding on it to get it back in shape.
So that biceps tendon, Popeye muscle in front comes up. The tendon, it goes in a groove between two bony bumps, right? This one's not grooved very deep, but there's a little bony groove there that should be in, and that bicep slides up and down in there. So you can sense that something kind of hard, like a bone, across the tendon with repeated movement might cause some irritation there. Definitely pain in front of the arm, pain lifting or reaching, weakness in the biceps muscle, pain with resisted elbow flexion. So anytime you want to try to flex that arm, that might be kind of painful. And again, possible neck or upper back irritation. Typically will not show up on CT scan, X-ray, or MRI. What does it need? We've seen this before. Proper examination is important. All right. So there's a lot of other causes that can cause shoulder pain as well. Some medical stuff, right? So we have to recognize that there can be medical stuff taken, so we do a good history to make sure you don't have something scary going on. I feel like if you Dr. Google some complaints, it always comes up like cancer, right? Like something incurable, some weird disease, right? Those things can happen. But, we tend to rule those out, but there's other causes of shoulder pain that aren't so commonly understood, so we're going to talk about some of those. Neck, T4, shoulder arthritis. So when I was first in training, back in Fred and Barney Rubble, back in the early 90s, when you had a pain somewhere, you only looked at that spot where you experienced the pain, right? So what I found clinically is, okay, I'm trained to do this, someone's got shoulder pain, I'm gonna go and treat that shoulder pain. And the challenge is not enough people got better. Not enough people felt the benefits. Because there's more going on than just where the shirt meets the sleeve. So this starts to talk about some of that. So where do the nerves to the shoulder come from?
The neck.
The neck, right? So would it stand to reason that if you got a jacked up neck that it could influence your shoulder? Yeah. So maybe the chiropractors are right to say, right? So that's true, right? So we'll talk about that first. So the nerves of the shoulder come from the neck. Signs and symptoms are people could have pain at the same time, neck pain, or they could have had a past history of neck trouble and a recurring history of neck trouble. Pain will oftentimes be in the whole region from the neck to the shoulder. Limited range of neck motion. Sometimes turn your head in particular ways will bring on the exact same pain. There will be muscle weaknesses in the back of the neck and upper shoulder as well, right? So, if you have the yowie here and you approach someone who's just a shoulder specialist, they're going to think everything's here, right? But neck pain can cause shoulder, neck involvement can cause shoulder trouble as well. We have approaches to test to see if that's going on. Because if we don't treat the neck in one of these conditions, even if they have some trouble with the shoulder, are they going to get much better? No, the nerves are all jacked up. So if you're not looking for any area other than where the yowie is, you're not going to find this, right? So it will not show up on an X-ray, CT scan, or MRI. Proper examination, subjective history. T4 syndrome. So the nerves for the sensation and the muscle control to the shoulder and hand come from the neck. The nerves that control the blood vessels and the autonomic system to the hand and the upper arm come from the upper thoracic spine, T4. So what is T4? T4 is that area in the back of the shoulder blade. You have 7 neck vertebrae. Here's your head. You have 7 neck vertebrae. 1, 2, 3, 4, 5, 6, 7. The next one attached to the rib, that's T1. First thoracic vertebrae. 2, 3, 4. So the T4 plus or minus a couple, when there's problems with the vertebrae between each vertebrae, there's stiffness or muscle imbalance, there's a problem with the rib, what that does is that can kind of jam up and cause misfiring of the nerves that supply the circulation to the hand. That's called the T4 syndrome. Does that make sense? I actually had T4 syndrome as a youth for a lot of years. Went to a lot of people trying to get improvement in my shoulder. Fortunately, didn't consult with a surgeon. But ended up my issue was I had T4 syndrome. Well, how do you know if you have T4 syndrome? What are some common symptoms? You can have pain in the shoulder that also perhaps some pain between the shoulder blades. Not always. You might have that. But specific, if we test that area, there's going to be undue tension and tightness in that area from a motion test. So we press on that area, it's like, ooh, ouch, even if they're not currently feeling pain there. Or there's certainly more stiffness in that area. Symptoms can radiate into any aspect of the shoulder. It could be the front of the shoulder, back of the shoulder, side of the shoulder, even down to the hand. If there's more than a couple fingers that the radiating is in, it's probably not the neck, but that's a little more nuanced. And it can mimic neck, disc, and nerve disorders. Hallmark feature is usually the muscle strength is fine. There's not an effective muscle strength. If the neck is involved, they'll be weak in the hand. But T4 syndrome, not. Anybody ever heard of this before? Most physical therapists don't assess or treat for this either. You do. It happens a lot. That's why it's included. Common theme? Sorry. You know the story. Shoulder arthritis. This is interesting, right? bottom line is shoulder pain and weakness is always a result of the arthritis. Does that make sense? That arthritis can occur over time. It's rare that we've seen shoulder troubles that can't get better because of arthritis. All right. Theoretical question. I'm asking the question, you probably know the answer, right? Yeah. You can have more than one darn thing going on at the same time, right? Almost always you do, right? So what I found over the years is that when we identify the types of things that are likely going on, start to identify the one or two things that are primarily going on and work on those, first, things get better. If we just look at one solution to shoulder pain, we don't get better. People who've been treated here, find that to be true? We treat more than one area, right? All right. So, precise diagnosis and treatment plan by Dr. Physical Therapy is necessary in my opinion, to avoid unnecessary surgery. We're not after pain reduction. There's lots of ways to get pain reduction. We can take CBD, THC, get a massage, take some medication, go get a bit tipsy with alcohol, a whole number of things, right? But that's not going to get your shoulder functioning better over time, right? All right. I'm going to do a 5-minute miracle. So, 5-minute miracle. This is my favorite part. Never know what's going to happen here. And what we do is we take a look at somebody who's willing to have me look at their shoulder to get a sense of what examination and a mini treatment might look like. Anybody want to volunteer?
Give it a pain.
Rock, paper, scissors.
There you go.
I'm intrigued by your front of the shoulder. No offense there. So we'll take a look at yours. So if you would please, we're going to direct a little attention over here because we may do. Candace, would you grab a pillow, please? And also out of one of the rooms, grab one of the going outers, big going outers, the measuring devices. All right. So come on up here if you would please. So we'll get started up here. So all right. Remind me your name, please.
Gary?
Gary, okay, Gary. So give me a quick 1 to 2 minute synopsis of your shoulder trouble. How long did you start?
It was good until about 3 weeks ago. I put the canopy on my boat cover, and I always had trouble getting my arm above my head. I hyperextended it because it was getting away on me from the wind. So I did aggravate it.
Hyperextend,
Like worked above my head because I usually can't get my arm any higher than this. So, and then since then, same thing. I can't sleep at night because I sleep in a fetal position. If I sleep on my back, I'm okay. I'm trying to.
So it really hasn't gotten better since then?
No.
What else have you tried to help this?
My daily exercises. I can touch my toes and reach for the sky.
Okay.
Without bending my knees. Still can do that 869. But this is where the problem is right there. I can do it.
Probably don't need to take measures there. We kind of see how he does that.
And it snaps. I just heard it snap.
Snaps, okay. I'm going to check a couple things for you, okay? First thing we're going to do is I'm going to bring your hands out in front of you. So obviously if you're coming in as an actual patient, I'll do a little more detailed assessment than that, right? But we're questioning than that. So maintain yourself here. Don't let me move you. Thank you. Hold here. Pretty painful. Was it painful or was it weak to start with?
No, it's weak to start with, but yeah, it's painful when you put pressure on it.
Bring your elbows in like this. Now you're going to bring the hand up to the side. It's called external rotation leg. We're testing parts of the rotator cuff muscles. His arm doesn't swing in, that's a good sign. This is a good sign, I realize that. Hold here, don't let me move you, don't let me move you. Good. Nice. We're going to test another one right away. We're going to do 2 tests on this side and then do one on the other side. This is called Napoleon's test or belly button press test. Maintain your hand on your abdomen, belly. Don't let me move you. We're testing different aspects of the rotator cuff muscle. Fair enough? As long as we're here on this side, bring your arm up. Slowly lower your arm down to the side. This is called a drop arm test. If I let go of that and it just flops down, not a great sign, right? We're gonna test one more. We're gonna test the smallest of the rotator cuff muscles. Hand back. Maintain yourself there. Don't let me move you. Don't let me move you. Don't let me move you. This is the smallest of the rotator cuff muscle. I believe this guy exercises on a regular basis because that's a very strong teres minor. Now push your hand forward. Flexion internal rotation test. Doesn't feel great, but reasonable. Doesn't elicit any symptoms on this side, but you don't have any troubles on this side.
No, that's my good
Fair
arm. Unfortunately, I'm right-handed.
Got it. So now we're going to do the external rotation leg. So you're going to hold your hand here. You can maintain his hand here. I'm happy about that. Let's see if you can maintain resistance. Hold, don't let me move you. Good resistance. I like that. Put your hand on your tummy. We're going to test another rotator cuff muscle. Bring your elbow forward. Elbow forward. Hold it there. Don't let me move you. Good and strong there too. I like that. Now we're going to do the drop arm test. Raise your arm up to the side with me. Now I'm going to let go. Slowly lower your arm to the side. It didn't flop down, right? That's what I'm worried about in that test. Not comfortable. It didn't flop down. So far, I'm less worried about his rotator cuff integrity, although I'm still suspicious. We'll find out what else is going on. This is kind of what I'm doing as the examination. I'm talking this out loud, right? I'm talking over, or thinking this to myself perhaps, but talking to the patient too. Bring your elbow up a little bit. Bring your hand back. There's no movement there. Okay? He's just stiff. Probably not the muscle's fault. It's just stiff. So we got to investigate that a little further, right? Because through the range that he has, hold it here, good and strong, but he's just as stiff, right? So, I'm starting to think he's got stiffness in that ball and socket joint, a form of frozen shoulder. I don't know. We're going to confirm that on the table. So we're going to have you come on over here to the table here. So we're going to test a couple things here. First, I'm going to test how much movement is in the ball and socket joint. So just allow me to move you. This is your good side. If I block the shoulder blade, that elbow should come up to about his earlobe with no movement in his shoulder joint. He's a little bit less, yeah, about there. Right? Definitely beyond 90 degrees, right? In this position, he can bring his hand back. A little bit stiff there, but pretty good, right? Not as much mobility as a left-handed pitcher, but not all. His muscles are going to stay quiet here. I'm trying to be out of view of the of everybody. He's not moving any further. He's got about 70 degrees of shoulder movement to the side or adduction. The other side there, about 100. Is that easily recognizable? If I don't block that shoulder blade, it's still a stiff, right? And then hand back, forget about it. Well, a little bit there. Come up here, he's got to bring his arm forward, he can't get back, right? He's got stiffness in that ball and socket joint, right?
Yeah.
A form of rotator cuff tightness. So I'm going to sit down, I'm going to do some gentle joint mobilization techniques with him. I might spin the table a little bit. Could you come up to seating, please? Come off the table. Lie back on the table again. I'm driving a photographer wild here. Oh, man. So, we want to do a physical assessment to get a reasonable idea of what's going on, right? And he could have some other things going on. This is limited scope, but I'm okay to do some techniques to see if we can do some of that shoulder joint, see what kind of immediate effect that has. Pressure's on me, buddy, so let's move on, right? Okay. Shift towards me a little bit. Shift your body, slide towards me a little bit. There we go. So what I'm going to do is I'm going to do some joint mobilization technique. This is a hands-on technique in which we're going to do slight motions through the ball and socket joint to help influence that area to get more flexibility in that area. Make sense? Everything I do here should be comfortable and easy going. Fair enough? Okay. So you just kind of relax as best you can. Let your arm rest. You're accustomed to moving it on your own all these years. Let your elbow rest as best you can. Okay, so I'm giving a little bit of traction here, like stretching that out like Stretch Armstrong. You remember Stretch Armstrong, right?
No,
Stretch Armstrong?
baseball player?
Toy, kind of stretched it out. Never mind.
No, before my day.
So we're doing a little bit of, it's not much of a spectator sport here, but I'm doing a little bit of mobilization to that area. Allow your elbow to rest as best you can. Comfortable?
Yeah.
Do you feel a little shifting in that shoulder joint?
Down a little bit.
So I'm isolating some movement in that ball and socket joint. In that shoulder joint, in any joint, there's a joint capsule. The joint capsule contains sensory nerve fibers that can feel about position and movement. And when we do this mobilization techniques, it has an opportunity to shift the pain level, flexibility, and muscle control of that area. Does that make sense?
Yeah, it does.
How's this feel, brother?
Better.
Feels comfortable? All right.
Can I take you home with me? Do this?
You should see those waves.
Oh, yeah, no. Should have brought my wife along and said, watch her now.
Right? So I felt that area kind of softening up. It was a little warm. I don't know if you felt that.
Yeah, I did.
I'm gonna have you come up to sitting. So we're not gonna fix all of his problems in one go, but we're gonna go back up there and take a look at what the result that has. Now, regardless of whether or not he can demonstrate a significant change in his movement, that was still a good outcome because we were able to get a little bit more movement. Go ahead and reach up now and see what you notice.
Oh, right there, she catches.
So reach up forward on both sides.
Hear that snap?
Hear the snap. Compared to before, what do you notice when you watch it move now? It ain't perfect, right? Anybody notice the difference? Faster doing it, a little more smooth. He's got a lot of stiffness there. Come on back down. Right?
Right.
What do you notice? Maybe not.
Yeah, I have more movement.
Yeah.
You know, I still have that impingement.
This is not the only thing he needs, right? He's got a lot of stiffness. So he's got a type of, not quite frozen shoulder yet at this point, but a lot of stiffness in that joint. Left untreated, I'm not scaring you to come and see us, but I'm left untreated, that's going to develop adhesive capsulitis. Because you don't move it, it's going to seize up, right? The body needs motion in certain areas. So, not a lot of weakness. His muscles probably got to catch up to that. So, his shoulder is not going to get better until that movement's freed up. So he's got a mobility impairment. That's his main thing. Yes, he's been kind of not using it normally for a while, so the muscles are going to need to be re-educated. There could be some other things going on contributing to this, neck and upper back. It's probably playing a secondary role, but you can always take a look at that as well. I'm really satisfied with that as an outcome. How about you?
Yeah, I definitely, you gave me a little bit more movement. What you did.
Terrific.
Yeah.
On your way out, pay Jackson your copay.
All right.
So, nice. So that's just a simple example of things. Now, we don't know what someone's going to present with. So someone's going to have the same type of problems. I didn't really assess a whole lot. If I did some pressure on his biceps tendon, that would probably be painful. Be painful because he's been stiff for enough period of time, right? So what treatment would look like for an instance like yours is the first phase, and we do treatment phases. So when we talk about proper treatment would be first phase is we've got to control inflammation and pain. A significant amount of your pain is created from stiffness. You've got some inflammation in there as well. So the joint mobilization techniques can help do both. You might very well benefit from some massage work to that area, or maybe even some laser treatment to that area to help lower levels of inflammation, right? To work through that. Then the next stage is we got to fix the root cause. The root cause is stiffness in that shoulder joint. We need to free up that stiffness. Does that make sense?
Yeah.
Then we need to help you move and re-educate those muscles within those newfound ranges. Right?
I guess.
I don't know what you all do other than boating, but you probably do some other stuff too. We need to then, final stages, we need to make him a robust human being and increase his strength so he can continue to do overhead stuff, so that next year, when he puts his boat cover in the wind and he does that, his muscles are much stronger and he's able to withstand that, right? Because you don't want to count on next year on just good luck.
Right.
So you need to develop a home exercise prescription that will involve strengthening exercises to keep you strong. Does that make sense? Because we want people not just to feel good, move well, we want some durability on that. Make sense? One session is not going to be enough. So that's what we talk about, comprehensive treatment, as an example. So, my name is Health Doctor Physical Therapy with pain interferes with your ability to sleep through the night. Don't suffer through the night, seriously, right? Family will appreciate it, your loved ones will appreciate it, and as a healthy healing, you can sleep through the night. Pain keeps you from thoughtlessly and fearlessly doing the things that you love to do. First call when someone calls you up and asks if you want to do something, it shouldn't be, oh, on my shoulder take that. That should be, what do I pack? When do I go? Right? And if you're fearful of losing your independence with overhead reaching, the longer that sticks around, that might be the instance. And especially if someone's kind of worried about you. Gee, why don't you go get some help? Maybe that's a simple, right? And you keep, trying to do things to ease up the pain, but you keep spinning your wheels week after week, month after month. And you're ready for another opinion, or some of you, first opinion. You can go to physical therapist first too, and you want a natural solution to your nape and shin. And you don't want to be worried about it, and have someone else worried about you. So, especially if you're interested in minimizing drugs, injections, surgery, certainly. Do we cure 100% of shoulders? We're close to, but not all. But at least you'd know. At least you'd be stronger for anything else that you might get down the road. Does that make sense? And body-based evidence doctor physical therapy exercise and treatment plan will include pain relief through joint mobilization. We did some of that. Muscle massage work. A significant portion of our patients do receive muscle massage work. Helps lower levels of inflammation and pain. Gets circulation going. Exercise prescription that's individualized to an individual and progressed over time. Develop a strengthening program.
I don't know if I see that one.
To get you better. We could provide pain relief through dry needling or laser. It could have an adjunctive approach to help speed that up. And I say that a modern evidence-based physical therapy plan of care is the treatment of choice to help get people to their goals for their shoulder problem. This is a pictorial evidence of a 4-phase plan of care. First phase, relief of pain and inflammation. Second phase, correct the root cause of the joint and posture imbalances. Strengthen within the newfound range. Preserve, make that human being stronger than before. All right, so we do one-on-one care. No offer education on other adjunctive treatments. Bias towards no medications, injections, or surgery. We can provide supplementation, lifestyle recommendations. Every little bit helps, right? So if you want natural anti-inflammatory, we can make recommendations on both dietary approaches and supplementary approaches that help lower your levels of inflammation to help your healing. You can't just supplement and eat your way out of this. You have to get some treatment for the shoulder too, right? So, where do you go from here? We're having a complete evaluation to find out what's going on in your circumstance. Take a history, do an orthopedic assessment as needed, muscle strength assessment, joint assessment, provide your doctor's report of findings for your individual situation, and help you with assurance on step-by-step way to get you back to where you need to go. And without downtime for the risks of surgery, injections, that sort of thing, right? So, how do you sign up? Erica, who's going to tell people how the next best step? Jackson, you want to take it?
Yeah, I can.
So I appreciate your attention. I know you guys, time is the most valuable thing we have, and don't take it lightly. You spend some of that with us. And Justin's gonna help, take care of the rest of the steps, so that you know what to do next.
Yeah.
Thanks.